The next presentation will be Professor Carlos D'Ancona, and he will present the module cystometry. Again, this is a module at work, so under development. We need your input, we need a discussion, and we practice our presentation and our webcasting of this. Carlos, go ahead.
Good afternoon. My task is about feeling cystometry. I'm a professor of neurology at the University of Campinas, São Paulo, Brazil, and Mário Gomes, professor of urology in Porto, Portugal. And the feeling cystometry is a system to evaluate the storage functions of the bladder, but also to provide objective evaluation of any dysfunction. Most of the time, we do this exam after medical history, focus on lower urinary tract symptoms after clinical examination to examine the saddle region and legs to see if have any neurology disease or dysfunction. Drinking void in the eye is important, free flowmetry and post-void urine residual. The feeling cystometry consists in register intravesical pressure and intra-abdominal pressure. This pressure is done by usually transurethral and intrarectal. The reference is zero pressure for atmospheric pressure, and we feel each volume per time. We can add electromyography, video, and rectal pressure, but this is addressed in other models. In the chart, we need to verify the scaling of the chart. In pressure channel, 100 centimeter water. In infusion volume, 1 liter. Have flow and voiding flow, this is another model. What information we obtain after feeling cystometry? About bladder sensation, cystomatic capacity, bladder compliance, and the detrusor function. Bladder sensation. We need to teach our patient what is first sensation, desire to void, or urge to void. We need to do some question to see what's happened. First sensation normally about 175 to 200 ml, about 30% of the capacity on voiding diary. First desire to void, 300 ml, 60% of capacity, a strong desire to void, about 40, 50, and 60 ml. Classification, normal, what we have seen, absent or atypical, absent, no sense, atypical, some discomfort in the bladder or pelvis. Late sensation, when the first sensations of feeling start after 200 ml. Hypersensitivity, early first and strong desire in reduced capacity. And pain need to be discussed in another model. Cystomatic capacity is a bladder volume at the end feeling phase. Maximum cystomatic capacity is when patient can no longer delay micturition. Maximum cystomatic capacity under anesthesia is volume of bladder without any leakage during anesthesia. And when the patient have no feeling, we can stop infusion after 800 ml. Bladder compliance is a function of bladder to hold a large volume of urine and low pressure. Describe relationship between change in bladder volume and change in detrusor pressure. One can apply this simple calculation, difference of volume divided by difference of pressure. We can measure the compliance at any volume and feeling, but usually at the capacity of the bladder. In this chart, we easily understand what's the compliance, increase feeling, and increase in pressure. We can also calculate the compliance, in this case, at 2.8. What's the normal value of bladder compliance? Are not precisely defined, but in patient without neurological disease is greater than 40 ml per centimeter of water, reduced less than 30. And in adult neurogenic bladder, when the value is lower than 10 ml per centimeter of water, have a high risk of upper urinary tract damage. Let's change about the Truser function. The Truser is equal vesical pressure minus abdominal pressure. We need to be aware that abdominal pressure is recorded in the rectum. Rectum contraction may occur, and the Truser pressure should always be compared with vesical pressure. Vesical pressure and abdominal pressure should always be in physiological range. Patients should balance pressure variation on movement, talking, breathing, coughing. So the Truser function we can consider normal when you don't see any phasic change in the Truser or intravesical pressure, or the Truser overactivity when you observe raise in pressure in the Truser and vesical pressure. We can classify neurogenic when have a neurological abnormalities, or idiopathic, we don't know. So the Truser overactivity is a wave in the Truser and vesical pressure. During feeling also and spontaneous or provoked, and may or may not lead to incontinence. So you can use the terminology terminal Truser overactivity, can observe on the feeling phase and the end of feeling phase, the Truser overactivity which incontinence will lead to incontinence, and there is no minimal pressure on diagnosis of the Truser overactivity and no standardization method to quantify the Truser overactivity. In this graph, we observe in the beginning of the trace the balance response for cough. In the feeling phase, we observe many contractions of the Truser and vesical pressure. And the end phase, also another contraction. In this other graph, we observe in contraction after provoked maneuver. After stress test, we observe here, and after Valsalva maneuver, Valsalva maneuver and contraction in vesicle and the Truser. About technique, how you proceed feeling cystometry. Normally you use double or triple lumen catheter. The size of catheter, 6 French for children, 8 French for adults. The third lumen when you want to measure ureter pressure. And they use the widest lumen for recording pressure. The single catheter for intrarectal pressure and should be covered with a flaccid balloon. We need to take attention to filling both catheter with water without bubbles, and connection tables also water without bubbles. But when you use a double lumen or triple lumen catheter, we need to have an infusion pump. What speed of infusion we need? We consider greater than 100 ml per minute fast rate, less than 10 slow fill rate. But we have no evidence for difference between 20 or 60 ml per minute, and this range is the most used in the normal evaluation. Voiding diets may help to choose an infusion rate. We can consider 10% of a largest voided on patient diarrhea feeling, maybe as a suggestion of the feeling rate. And we need to realize also the physiological feeling rate is usually 1 to 2 ml per minute. About the solution infused, normally you use saline solution. When you perform video urodynamics, you add contrast. Normal temperature is a standard. We can use also body temperature. And ice water is more focused in neurogenic disease, neurogenic bladder, and not addressing this model. The transducer should be positioned at upper level of symphysis pubis. And the position of the patient can be lying, sitting, or standing. What preference position to do this feeling examination? The sitting position is a standard. In men, when we want to also see a pressure flow study, we prefer standing. The supine position if the patient cannot be sitting or standing, and this voiding is impossible or not needed. Always we need to be careful to close as much as possible the patient and not use a lithotomy position. The resting pressure changes depending on the position. In supine, change 5 to 20, sitting 15 to 40, and standing 30 to 50. Why is this variance? Because depend on body mass index. What's important points in feeling cystometry? All negative values should be corrected. Correct 0 atmosphere in both lines, correct calibration in both lines, and flush air bubbles and breathe of both lines. Abdominal pressure is to independent movement influence on vesical pressure. Be careful about the detrusor pressure cannot be negative unless rectal contraction activity. So we can summarize feeling cystometry. Cough test verifies both lines register correctly. Live signals, movement with breathing. We have initial resting pressure. And we need to also signalize the end of the feeling phase and volume, and also mark in the chart the sensation of the patient. If you don't want to run any risk, we need to have a really good quality control. Thank you very much.
Thank you, Carlos. Again, about the content and about the module and about what has been said, what's missing, what we should do, what we should aim at, and what we should not do.
I prefer every time when an ICS standard is changed or a new one is suggested that it's made clear that there is an old standard and we want to change it and argue why. So for the filling speed, the ICS standard is very clear. We differentiate between maximum physiological filling and above, which is then calculate roughly body weight divided by 4 kilograms in milliliter per minute. That's the ICS standard. If you want to introduce a new ICS standard, I think you should first discuss it with the standardization committee and then come up with arguments why you think it should be done. I'm now involved in a pediatric study where they came up with this idea using 10% for maximum voiding diary or catheterized volumes in neurogenic kids. And I realized this is not a very good value because some of these kids then catheterized by 300 milliliter, and now suddenly you fill a neurogenic bladder with 30 milliliter per minute. That's not a good idea. That was one thing. And the other thing which I'm struggling with myself all the time, particularly when you do urodynamics in older people, that is the maximum capacity. It's very difficult to tell when to stop filling. When you have a patient who has urge incontinence or whatever, then everything is clear. Suddenly you say, oh, I have to, I cannot, or leaks or whatever. But I see these old ladies, although diagnosed objectively with urge incontinence, they may lie or sit on the urodynamic chair, and you fill, and particularly when you fill slowly, and then at 800 you slowly think, oh, I better stop. You know, this is a very critical parameter, and I'm not sure how much that has to do with maximum bladder capacity. I better would take this from the voiding diary. But the question really is, when should you stop? And that's the same, for example, with neurogenic children. You can fill them forever. And unfortunately, in that study I'm involved, some of these children are filled up to a detrusor pressure of 100 centimeters of water. I said, how can you do that? You know, you should stop at 40. So I think you need a lot of good criteria to define when to stop filling and how to label this, whether you think that's maximum capacity or, for example, in neurogenic children, a safety thing, maximum 40, or whether. This is a very critical value to make cystometry comparable.
So we went on to show just very basic fillings and don't address to neurogenic kids. It's very, the other system, So the
I appreciate that, but you know, when you make a simple statement that stop filling at maximum capacity, what does it mean?
No, stop filling at 800 because of no sensation at all is in fact not maximum capacity. I agree with that. But we agree on stopping at 800 and the non-value of filling above 800 when there's no sensation at all. And I think that's the message, although it's not defined as maximum capacity yet. But it's not defined at all, this situation. So that is a challenge for the new good urodynamic practice standard. As far as sensation concerned, what this slide says and what the good urodynamic practice, as well as the terminology says, is that you go along the steps of first sensation and normal desire and strong desire. And when you miss the first sensation, and you're still waiting at first sensation at about 500, 600, you will know that nothing's going to happen after that if nothing happened before. So that's the practical of it. And you need to have the sensation landmarks and not talk or leave the room and come back when there's 800 in the bladder and say, do you feel anything? No, then you are too late to discuss. That is the background, but it is on the slides, and it is on the basis of the guideline and good urodynamic practice, and also the filling rate is not conflicting with what is in the standard and the good urodynamic practice.
I agree with that we should call it physiological or non-physiological, and add correct formula. And then in the bracket, usually it is this and this. And then when we're talking about unphysiological, then we can say over 100 or under 100. But the basic distinction is physiological and non-physiological.
But then,
or maximum.
But the maximum physiological is never above 10 or
but
it's about body weight divided by 4.
Yeah.
But it's not in our standards.
It is ICS standard. Yeah.
It's specifically in the
for the children.
No.
Oh, good. Oh, good.
And anyway, so the other comments is when to look through the slides, I will start with patient preparation position, not at the end, but at the beginning. That this third one, some of the graphs are a little bit confusing. It shows valsalveolar leak point pressure, and you only wanted to show there is a contraction after stress. So that shouldn't be there.
No, because after the Truser overactivity, now I show provoked the Truser contraction.
Yeah, but that's not leak point pressure.
Okay,
because either you. It's not the same thing.
I understand. We just cut valsalveolar leak point pressure.
And also, I will remove one of the channels which shows what is the speed of feeling, and it will give you a little bit better layout.
Yeah, it's
also okay.
We miss a standard layout. Okay. Okay.
What I'm saying is that when you are doing urodynamics, you trace the filling dynamically. When you're teaching urodynamics and you see it as the composite, it's not quite the same thing. You want people to see, you can then stop it, say, right up this point we've had a cough. Then you can start it again and show the next bit. But for somebody learning, that's more meaningful.
Right.
A couple things. I think in the document, in some places it says water, other places it says saline. It ought to be consistent, one or the other. Second thing is compliance. Compliance is like pornography. I mean, everybody thinks they can recognize it, but nobody can define it, especially decreased compliance. So I think there has to be examples in there, because what happens when you fill and then you stop filling and the line goes down. Where do you measure the compliance? And when you have an involuntary bladder contraction, and just before that, the detrusor pressure goes up. I mean, this is very easy here because it's a standard example.
Okay.
Yeah.
But there are a lot of them that aren't standard. And Werner's right about the filling. 2.4 times the hourly diuresis was Bjorn Claymork's number. Anytime you fill above that, you distort the compliance limb.
So your idea is an advanced module on compliance?
Well,
I think
no,
that,
but just some examples about what you do in the cases that happen frequently. In other words, you stop filling here and the detrusor pressure line goes down. Where do you measure compliance? Do you measure it at 63 or when it drops to 40 when you turn everything off?
Yeah.
Or when you have an involuntary bladder contraction without leakage, and after that the pressure line drops to what it was, or
I'm
to a
afraid
point
that we
below.
all have opinions about that, but not too much evidence again.
Right, but
But
then
yes, it's the problem.
then we
Yes.
then we should say that there's no consensus about
And we
what to
need-
do in those cases.
I believe it's a good point. Acho que you did
Yeah,
put
sure.
in the model. Yes, thank you.
So the observations need to have a title or something to describe it, and then we can standardize it, and then we can evaluate the value in clinical perspective. But yeah, we have all our ways of dealing with this kind of curves and this kind of observations during urodynamics, but it's little standard. Who is relatively new in urodynamics? Excuse me.
Alan, please. So you think if I present 2 or 3 examples of compliance, like involuntary as this, and though you is better understood?
Yes.
Okay.
So can we include this?
These
in
2 or
this
3
module?
examples to clarify what we consider low compliance.
Right. I mean, everybody here who does and looks at 10 of these a day knows that out of those 10, there are going to be 5 that aren't so classic. That's the problem. So.
Okay. Okay. Thanks.
Can you also define what is low compliance or reduced compliance?
Well, it's classified as when the bladder loses the capacity of a long volume and low pressure. Big volume, low pressure.
Yeah, in your slides you said less than 30 is reduced compliance, but the upper urinary tract getting affected is only after less than 10. There are several studies saying it's less than 20. It's quite variable when we should be taking the cutoff at what point.
Less than 10 in urogenic bladder, and the normal patient is not very clear what is normal, or we consider normal greater than 40, but not really a number.
So what is happening between 40 and 30 and 30
Nobody
and 10?
knows.
Okay.
So, but may I ask you a question?
Yeah.
Suppose that we say this is it, and we say, or any cutoff values, put in compliance and put in cutoff values. Basically, I have 2 questions. When are you going to challenge us because of the lack of evidence? And what will be the consequences in your practice of this module without this being standardized or without evidence? So would you change your practice on the basis of an educational module, or would you change your practice only on the basis of a standard or as much as science as you can find? What would be the effect?
My question is, when in non-urogenic patients, when should I start worrying about upper urinary tract?
If we say on the basis of expert evidence in this educational module, and we say, okay, 30, above 30 is very, very dangerous, would you be influenced by that?
No, but we look forward to the ICH
Why not?
recommendations, and with regards to compliance, it's not been defined. There's so many definitions for the last few years.
Yes.
But this aspect of bladder compliance has not been defined so far.
No, sure. So we agree on that. There is no good definition and no good clinical, let's say, action limits. We have a few on neurogenic and on maximum intravesical pressure or detrusor pressure. Yes, we have some ideas.
All the evidence is on urogenic bladders.
Yeah.
There is nothing much on
Doesn't
urogenic
transform
bladders.
to. Okay. So we agree that there is a lack of that evidence, but you're still asking for us to put something on the slides. So it's something, it's very basic. This is going to account for every educational module that we make.
But
And
Peter,
this
you cannot say we make it so simple when it's not.
It's not, no.
You know, the problem with compliance is, first, we all agree, I think it depends strongly on the filling rate. So when I see these linear increase, I always suspect there was a very fast filling.
Mm-hmm.
That means if you fill them with what we call maximum physiological speed, there may not be any reduced compliance at all. Then there is consensus, and I think it says in the standardization document that, of course, determining compliance, you have to exclude any active detrusor contraction. So that is important. But the compliance statement actually only makes sense together with a filling speed statement, because one is depending on the other. And usually, of course, you know, that's a nice, simple example, but usually the filling curve is different. It's not linear. It's somehow, you know, you may upfill to 400 milliliter and there's no pressure rise at all, and then it goes up. Or as I see in my old ladies, I fill them to 800 and there's no pressure rise. There's an endless compliance. So, you know, if you want to define compliance, you have to at least vaguely, I think Alan suggested already, give various examples of these types, what you have to look for. Otherwise, I think it's not useful. You know, when you know up to 300 milliliter there is no pressure rise and have a neurogenic bladder or whatever, then you can give suggestion, okay, you have to catheterize every 300. Yeah? But if you have this kind of rise, you know, then that's a completely different situation.
Sure.
So, yeah, I think when you describe it and define it, it should be done in a way that it somehow reflects the real life.
Yes, I agree with your comments. And yes, there are different types of compliance. And yes, there might be an association with filling speed. Again, not too much evidence. But the first step is to recognize compliance as a urodynamic entity. And that is the first step in education. What you can see in the detrusor curve is that it's flat, it is moving all around, or it's rising continuously, or any combination of that. And as far as we are in pattern recognition, we should educate those patterns. And then in the advanced, we should show how combinations are recognized and what's the clinical relevance. But the clinical relevance is after the test. It's not, it's during the test, of course, but it's not the observation is apart from the clinical relevance or the clinical cause. That would be my background in your answer.
Yeah, I think the problem is that most people, when they use the curve clinically, they use it in terms of centimeters of water pressure and not compliance numbers, because people get the two confused. So maybe it would be helpful in something like this to say, you know, 40 mLs per centimeter of water translates to an end pressure of X at so many centimeters of water capacity, just to give people an idea. Because really, you don't, I mean, if you look at a curve, what do you look at it for? You say, well, just like Werner said, this person can catheterize up to here and not be in trouble. But if you think the number's 30, then you say, well, you had to catheterize before the pressure gets to 30. So maybe a correlation, just an example, between pressure and compliance at a given volume would be helpful.
Especially a module for patients like what you're intending to, or what you're aiming at is patients do self-catheterization and with no sensation at all and maybe bad bladders or better bladders than bad bladders.